Hello, everyone, and welcome to the Advanced Pathophysiology podcast. And our subject for today we will be covering is hematology. And we're so happy to have with us Taylor Dana, who is a alumni of FRANU FNP, the class of 2021. So help me welcome Taylor, and she's going to give us a little bit of background about herself and the work that she does.
Yeah, so my name is Taylor, and I graduated from the program in 2021, as Dr. Gallo said. And since that time, I've been working for Mary Bird Perkins Cancer Center. We deal with a myriad of disorders that are oncologic and hematologic. We mainly focus on oncology disorders, but we do deal a lot with hematologic disorders as well. So when Dr. Gallo reached out to me to come and, talk about some of these common hematologic disorders that are going to be seen in primary care, I was more than happy to come and speak about this today. So I'm excited to be here and, answer some questions and kind of give some more information for you guys to learn and grow for your practice as you go into the future.
Okay. Well, thank you so much for taking time out of your busy schedule.
Of course.
So we'll jump right into it. Our focus today will be more on the anemias.
Sure.
And so we know that anemia is a very common problem in primary care and just across the healthcare delivery system as a whole. Can you tell us a little bit about exactly what anemia entails? Maybe how do we develop anemia, and what are some of the mechanisms behind people developing anemia?
Sure. So anemia is really one of these things where I like to call it's not a disease, but rather it's a sign of an underlying disorder. And it can really be multifactorial. And so anemia is defined as a reduction in the number of red blood cells, the hemoglobin concentration, or the hematocrit. So what you're going to be seeing in practice is for men, that number is going to be less than 13.6 grams per deciliter. And for women, you're going to be looking at a hemoglobin less than 12. And when you kind of characterize anemias, you can really let the lab work do a lot of the diagnosing for you.
Okay.
So as we know, red blood cells are the cells in our body that help carry oxygen. They contain millions of hemoglobin molecules that bind to oxygen and carry it to our tissues. Reticulocytes, or those premature red blood cells, enter the bloodstream, and then about 3 days later, they become those really mature red blood cells that we know in practice, and they have a lifespan of about 100 to 120 days. And when we talk about classifying anemia, we really look at disorders of impaired red blood cell production, acute or chronic blood loss, and then increased red blood cell destruction. So that's kind of how you can think about it and break it down as you kind of go through the lab work.
Okay. And so oftentimes we'll hear of different anemias or anemia terms such as normocytic, normochromic anemia.
Right.
Can you tell us a little bit about, in terms of the cytic classification and the chromic classification, how does that apply to the classification of anemias?
Right. So when you're looking at a CBC and you see that someone's hemoglobin is decreased, really where my mind goes to next is that MCV, which is going to be that size of the red blood cell, which is where you get that cytic ending, right?
Okay.
So you're looking at microcytic, normocytic, or macrocytic. So microcytic is defined as MCV less than 80. Normocytic is going to be 80 to 100. And then your macrocytic is going to be greater than 100. And sometimes it can be hard when someone is anemic, but their MCV is normal. And so what I tell people is when you see someone who's anemic and they have a normal MCV, you should really be checking that reticulocyte count, because if it's high, you can be really looking at more of a hemolytic anemia or a blood loss. If the reticulocyte count is low, that could signal a bone marrow disorder such as an aplastic anemia, where the bone marrow is unable to produce that adequate amount of red blood cells. And then when you get into talking about the hemoglobin content, which is that chromic ending, you can be hyperchromic, normochromic, or hypochromic. So that's really looking at the hemoglobin concentration of that red blood cell.
Okay, so cytic, we're looking more at the size of the red blood cell, and then chromic is more the hemoglobin content.
Exactly.
Okay,
Exactly.
and you mentioned something key, that when the MCV is normal, then we should be looking at the reticulocyte count.
That's right.
Which then will give us an idea as to what possible disease process lies ahead.
Exactly,
Okay.
because it can be hard. We know that microcytic anemia is more associated with your iron deficiencies, right, and your blood loss. And we know that macrocytic is more associated with your B12, your folic acid. But when you have that cytic, it can be sometimes hard to differentiate. What am I dealing with here?
Right.
How do I break down my differential diagnosis? And so that's when you can use that reticulocyte count to kind of guide you.
Gotcha. Okay. So now that we've kind of gotten some of the color and size of red blood cells out the way, I'd like to now shift our focus to a little bit about the different types of anemia.
Sure.
Okay. We know that there are a lot of different types. So the first type I kind of want to touch on, which kind of is self-explanatory, is the anemia of blood loss, such as a post-hemorrhagic anemia.
Exactly.
Can you kind of expound on that for us a little bit?
Sure. So when you're looking at the hemorrhagic anemia, this is an acute loss of blood from the vascular space. And the major cause of that is going to be trauma. So you're looking at gunshot wounds, stabbings, car accidents, AAAs, and you're really seeing at that point some cardiovascular compromise. These patients are severely anemic, they're severely symptomatic, and the focus at that point is really to replace that blood volume, fluid volume, back into the vascular space, as you kind of mentioned on the PowerPoint, some albumin, some plasma, some fresh whole blood, really focusing on getting that vascular space full and resuscitating the patient back to a stable, condition.
Right. Okay. Yeah, so it kind of speaks for itself because there's been a lot of blood loss, and as you mentioned, what can we do urgently to replace that intravascular volume? Okay, and we've kind of already alluded to it, but we'll go into it a little bit more, talking about the macrocytic anemias, where we're dealing with red blood cells that are usually larger in nature.
Right.
And you kind of mentioned two of them, well, one of them, vitamin B12 deficiency, and then we also know that folate deficiency is a macrocytic anemia as well. Can you kind of give us a little bit more background on those two anemias?
Sure. So talking about the B12 first, these red blood cells are going to be unusually large. You're going to see that MCV greater than 100, as we mentioned earlier. You're going to see an elevated MCH of that hemoglobin concentration. And you'll see the word megaloblastic. And what that means is when they look at that red blood cell smear under a microscope, what they're seeing is large, immature red blood cells that are oval shaped and a lot of times have hypersegmented neutrophils as well. And you can kind of differentiate that from a non-megaloblastic anemia in that the smear of a non-megaloblastic, you're going to see large, mature red blood cells that usually signifies alcohol abuse, hypothyroidism, and pregnancy as a potential cause. Now, vitamin B12, of course, is an enzyme that we need for DNA synthesis, and if we're deficient in B12, then we're unable to synthesize DNA, and we're not able to progress to that mitotic phase of the cell cycle where the red blood cell is able to reach that normal growth and maturation. So both vitamins, B12 and folic acid, are essential for normal DNA synthesis, and bone marrow is very sensitive to those deficiencies.
Okay. In terms of a vitamin B12 deficiency, what are some of those classic presentations that you might see in a patient that presents to the clinic with a vitamin B12 deficiency?
Sure. So we use the term pernicious anemia, which is the most common cause of macrocytic anemia, and it's caused by B12 deficiency. And what it really boils down to in terms of pathophysiology is lack of that intrinsic factor, which is a glycoprotein from the gastric parietal cells within the gut. And parietal cells are specialized cells that line the stomach that play a crucial role in gastric acid secretion. So antibodies bind to that intrinsic factor and they prevent the absorption and binding of B12. And so the kind of classic signs and symptoms that you may see in a patient with this are weakness, fatigue, numbness and tingling of the fingers and toes, difficulty walking. They may have loss of appetite, abdominal pain. We use that term atrophic glossitis, which is that kind of smooth, beefy red tongue, right? And sometimes, on imaging, if you're looking at these patients, you may see hepatomegaly, splenomegaly, and really the most detrimental part of B12 deficiency that goes unrecognized is the neurological symptoms, right? Because if those are not addressed and treated accordingly, they can be permanent if the symptoms persist for longer than 3 to 6 months.
Okay. So would it be wise then to say that any patient that presents with, say, peripheral neuropathy, one of the things that must always be included in that differential is a vitamin B12 deficiency?
Always. And it seems so simple for someone to come in and say, I have neuropathy. I mean, they may have diabetes or some type of pre-existing trauma where they have nerve damage, but you never want to rule out a B12 deficiency in someone who says, I have this, paresthesia of my fingers and toes, because that's something that could be easily identified and corrected and that you don't miss, and it potentially can save the patient's life.
Right. And then kind of tacking on to that, you mentioned intrinsic factors. So for those patients in an era where weight is a big issue, we know that many patients then go to have weight loss surgeries. And if we're dealing with the stomach, and it's the stomach that's where the intrinsic factor is that's necessary for the vitamin B12, what impact does that have? Is that a patient that will have to be on lifelong B12, or what implications does it have for the patient who's had a gastric surgery?
Exactly. So patients who have had gastrectomies or ileal resections, they are going to be more at risk for that decreased absorption, and so those patients are going to be more likely to require lifelong supplementation. And so that's even patients who are on things like proton pump inhibitors, H. pylori, chronic gastritis. And one of the things I was going to mention too is these patients with B12 deficiencies really need to be evaluated with an EGD. And we really do that on an every 5-year basis, because patients with B12 deficiency have a 3-fold risk of developing gastric cancer. And so it's very important that we kind of go down, we look at the integrity of the stomach, make sure that there's proper absorption, so that we can properly take care of the patient.
Awesome. You bring out a great point, because, being in primary care, we see that 75% of patients are on proton pump inhibitors for acid reflux because of our diets, of course.
Exactly.
And when we talk to patients about pulling them off, they feel like they can't go without them, but they're at risk for development of a B12 deficiency. So that really should be a conversation that we're having with our patients.
It is, and it's not an absolute contraindication to pulling those patients off of that medication completely, but it is just something to consider as a risk factor when you're evaluating someone for a B12 deficiency.
Okay. And folic acid deficiency, maybe a little bit of insight on folic acid deficiency?
Sure. So folic acid, again, is a vitamin that helps make DNA, repair DNA, and produce red blood cells. We mainly get this from dietary sources, including fruits and vegetables. The absorption of folic acid occurs in the upper small intestine. So patients with things like celiac disease, IBS, history of gastric bypass, again, you're seeing some drugs, even methotrexate, Bactrim, metformin, that can impair the synthesis of folic acid. And so folic acid is really mandatory for the fortification. mandatory folic acid fortification has dramatically reduced this problem worldwide in our
Gotcha.
foods, right? Because, it's important to counsel our patients on dietary counseling. Green leafy vegetables, meat from animal sources, fruits, nuts, liver, foods with yeast, fortified cereals. A lot of that has kind of taken the folic acid deficiencies out of the primary care setting, but
Gotcha.
you never want to completely rule that out, because you can kind of see some of the same clinical manifestations with a folic acid deficiency as you can with a B12.
Okay.
And oftentimes they can go together, B12 and folic acid deficiencies, and so if you're checking for one, check for the other.
Always check for the other one. Okay. Okay. And so, with that being said, now we want to kind of shift our focus to probably the most common type of anemia worldwide, which is iron deficiency
Yep.
anemia, which is a microcytic hypochromic anemia. Can you give us a little bit more background into iron deficiency anemia?
Sure. So, like you said, this is the most common type of anemia worldwide, and what we really see this as a disorder of iron metabolism. So, this most commonly affects women of reproductive age and older adults. It can be caused by blood donation, as we just kind of had a conversation with another colleague about that. It can also be associated with anemia of chronic disease, but our highest risk group is going to be toddlers, adolescent girls, women of childbearing age, those living in poverty who may not have access to those foods that are fortified with iron,
Right.
infants consuming cow's milk without that iron fortified milk, older adults on restrictive diets. I loved what you said about teenagers on junk food diets. I was one of those at one point. But causes can really be a dietary lack, impaired absorption, increased requirement for iron, which we see during pregnancy, chronic blood loss, so women who have mild to moderate menorrhagia, right? Chronic blood loss can even be GI bleeds, where you can lose just even a few tablespoons of blood per day, microscopic hematuria. Those can kind of be slower onsets where it's not as acute of an anemia. And then we're not really seeing symptoms sometimes until that number gets as low as 7 or 8.
Okay. And so, with that being said, with those pathophysiological mechanisms that lead to the iron deficiency anemia, what clinical manifestations or what signs and symptoms will be obvious with the patient who's deficient on iron?
Sure. So, like most anemias, you can expect some fatigue, weakness, a little shortness of breath, some nail integrity changes, those spoon-shaped nails, the brittle, thin nails. One thing that I like to always ask patients about in clinic is pica symptoms, so craving for things like ice, starch, clay. And then one thing I really wanted to point out to the students, especially in primary care, is anytime a patient comes in complaining of restless leg syndrome, you always want to consider that iron deficiency may be a cause, because a lot of people don't consider that as one of the reasons, and they just may refer out to neurology or whoever, but it may be as simple as checking that iron level. You replace that iron and that restless leg syndrome gets better immediately. So those are some of the kind of manifestations you can see.
Great. And I'm glad you bring that up, because I had a patient with the same symptoms, restless legs always moving at night, checked her iron. She was deficient, replaced it, and she felt like a new person after
Exactly.
replacing the
It
iron.
happens a lot, and that wasn't something that I learned about until I got into practice, and it is very common. So that's something to consider when you're going through your practice.
Okay. And in terms of just a little bit on evaluating the person with an iron deficiency anemia, what would be the best test to order, and how long should we wait to recheck those tests after the patient has been medicated
Sure.
to see a noticeable difference?
Right. So this is a great test question too. Ferritin is the gold standard
The gold standard.
of,
Okay.
of checking for an iron deficiency. Of course, you can check, an iron saturation, a total iron binding capacity. Those are great things that can help lead and guide your diagnosis, but a ferritin is going to be your most precise measurement of improvement, okay? And so if I'm, giving a patient IV replacement iron, I'm bringing that patient back in about 6 to 8 weeks. I'm rechecking that ferritin, I'm rechecking that hemoglobin and that MCV to make sure that, one, the numbers are improving, and then two, that the clinical manifestations have improved.
Okay. Okay. And what is it? You mentioned ferritin. Can you tell us a little bit about what exactly is it that ferritin measures?
Right, so ferritin measures the free iron stores in our body.
Gotcha.
So that's going to be why it's your gold standard, because that's going to show you what is truly the circulating iron store within the blood.
Gotcha. Okay. Really good information on iron deficiency anemia. We'll shift our focus now to anemia of inflammation. So we live again in a culture where a lot of patients suffer from inflammatory disorders. And so a lot of times we can see anemia of inflammation or anemia that's related to inflammation. Can you tell us a little bit about the pathophysiology or the mechanisms behind the anemia that's related to inflammation?
Sure. So anemia of inflammation is also kind of interchangeably used with anemia of chronic disease. And this is the second most common type of anemia out there, secondary to iron deficiency. And what you're really going to be seeing in practice is a mild to moderate anemia from the decreased erythropoiesis, which is, of course, the production of red blood cells. So you may see a hemoglobin of anywhere from 9 to 11. It's not going to be, it can be severe, but normally it's going to be more in that mild range. And we're really looking at chronic systemic disease or inflammation. So patients with infections, HIV, cancer, which accounts for more than 50% of cases, inflammatory or autoimmune diseases like rheumatoid arthritis, systemic lupus, sarcoidosis, CKD, all those inflammatory cytokines kind of impair the erythropoiesis, which is going to impair that red blood cell production.
Okay.
And it's important to manage the underlying disease or condition, because older adults with anemia of chronic disease have a 5-fold higher risk of morbidity, mortality, and hospitalization. So the focus is really on managing their underlying disorder, so you can see that hemoglobin actually improve or stabilize, so that their condition can be stable.
Okay. So take, for example, the patient who has some chronic kidney disease. It would be very important for us to try to manage that kidney disease as best as possible,
Exactly.
which then would improve the patient's anemia.
Exactly.
Okay.
And when you're dealing with a chronic kidney disease, you're going to have a renal doctor on board. They're going to be managing medications and things to help improve their renal function. But you always have to consider, okay, if a patient has chronic kidney disease, that erythropoietin, which is that hormone that stimulates red blood cell production, is going to be impaired.
Okay.
And so you're going to see some degree of anemia with a chronic kidney disease.
Okay. And kind of coming down to our last two anemias, not often seen in primary care, or if it's seen, maybe primary care providers don't really know what's going on with the patient. But when we're talking about aplastic anemia, you mentioned something about some of the autoimmune disorders can cause some anemia of inflammation, but what about the aplastic anemias?
Right, so aplastic anemia is a little bit deceiving in the name, only because with aplastic anemia, you're going to see a reduction or an absence of all three types of blood cells. So your red blood cells, your white blood cells, and your platelets. And most aplastic anemias are autoimmune disorders. Some can be due to chemicals, drugs, unpredictable exposures, inherited, or idiosyncratic as well, but most are autoimmune. So in primary care, if you come upon a patient and you see a decrease of all of those, your eyes are going to go like this. But take into consideration you may be dealing with an aplastic anemia, and really at that point those patients need to be referred out to a hematologist.
Gotcha. And you mentioned something key with aplastic. You're dealing with all three of the blood cells,
Exactly.
as opposed to just the red blood cell.
Exactly, and that's how you can kind of differentiate from a pure red blood cell aplasia, which is just going to affect those red blood cells.
Okay. And then lastly, anemias where the cells are destroyed, or anemias of increased destruction, such as hemolytic anemia.
Yeah.
Can you tell us a little bit about how does that come about?
Right. So, hemolytic anemias are rare, but it is an anemia of increased destruction, as you said. The most common being sickle cell disease, something that is very common, right? That we
Right.
see a lot. Chronic severe hemolytic anemias that result in destruction of erythrocytes. This is talking about sickle cell. The cells are stiff and unable to change shape, causing vascular occlusion, pain, and organ infarction. Again, these can be autoimmune disorders as well. They can be associated with viral or bacterial infections. And the way we diagnose an autoimmune hemolytic anemia is through a Coombs test, direct and indirect, to screen for those antibodies.
Okay. And any specific maybe clinical manifestations that you may see in the patient with the hemolytic anemia?
Sure. So these are hemolytic anemias are actually a lot of times well compensated for. And when we start to see things like jaundice, aplastic crisis, splenomegaly, these are complications of severe hereditary, what we call spherocytosis, where the red blood cells are abnormally shaped. And that's when you're really dealing with the more severe symptoms. But for the most part, hemolytic anemias are well compensated for. So, you may see some of that fatigue, pallor, weakness, shortness of breath. But a lot of times it's just kind of, making sure that their symptoms stay stable, unless for some reason they progress to those more severe symptoms like the jaundice, the abdominal pain. And then you want to do a little bit more investigation at that point.
Okay. Well, thank you. I think this discussion on the anemias has really been good, because I think it provides the students with some good clinical pearls and nuggets.
Yes.
That helps to differentiate among the different forms of anemia. Just before we go, I thought that we would kind of discuss another common condition seen in primary care, and it's a myeloproliferative red cell disorder that we know as polycythemia. We see it often, as I mentioned, in primary care, but can you share with us a little bit about exactly what polycythemia is?
Right. So when you're looking at that overproduction of red blood cells that occurs, some of the clinical manifestations of polycythemia that you can see are dehydration from diaphoresis or excessive sweating. You can see some transient neuro complaints such as headache, blurred vision, tinnitus, burning of the hands and feet with erythema or cyanosis. But again, those blood clots are going to be the most serious complication. And so as the clinician, your main goal is to kind of put measures in place to prevent things like heart attack, stroke, hepatosplenomegaly, and those sorts of things.
And so you did kind of mention already, but in terms of treatment, a lot of times, phlebotomy is one of the ways
Right.
that we can get those red blood cells counts down.
Right. And so the goal is to decrease hematocrit levels to less than 45% in men and less than 42% in women. So the phlebotomy, withdrawal of 300 to 500 milliliters of blood at a time to reduce the erythrocytes and blood volume. Low dose aspirin. This is for low risk patients, so they can do that baby aspirin daily or twice a day. And then for your higher risk patients who have abnormal heart caths, smokers, alcoholics, age greater than 60, previous heart attack or stroke, then you're going to be looking at possibly implementing some medications such as hydroxyurea, interferon, or that radioactive phosphorus that Dr. Gallo put on the PowerPoint for you guys.
Okay. So in primary care, then, when we're seeing these patients that have a social history of cigarette smoking, or maybe they've lived in places with high altitudes, or they're on
Right.
testosterone, then the light bulb should be going off that we should be monitoring their CBCs closely
Yes.
to make sure that they don't develop any polycythemia.
Exactly, and it's not always something that has to be referred out to a hematologist. It can be something that's managed by primary care. But if you're dealing with a JAK2 mutation, that is something that you want a hematologist to manage and evaluate, so that they can be put on that hydroxyurea and get that medication and treatment that they really need. So
Sounds good. Well, Taylor, you've been most helpful on today. You've provided us with some invaluable information because we know that the anemias can be so broad. But you've
yes,
given us some pearls and some nuggets. I think that will really help us to differentiate the different anemias, and not only for the students, but I must admit that I've learned a couple of things from you that I plan to take back into my primary care practice. So we are truly grateful that you took time out of your schedule to come and share some of your hematological experience with us.
of course, this was a great experience. It's always good to collaborate with colleagues and students, and this experience has been so wonderful. And I hope in the future that if you ever need anything again, you will reach out to me. Like I said, the PowerPoint that I put together was a little bit more in detail, and so I will share that with Dr. Gallo so that he can distribute it to y'all if y'all would like a little bit more information on some of these hematologic disorders, just to take a deeper dive for your future practice going forward.
Great, great. And I'll be sure to share that PowerPoint with all of you. So thank you for joining us for our Advanced Pathophysiology podcast. Topic of discussion was hematology. This was great, and hopefully we can look forward to many more podcasts in the future.
Thank you.